Chapter 22, Abdominal Emergencies. The abdomen contains many organs, and they also involve several different body systems. So this can cause some confusion when determining the cause of abdominal emergencies. You got to thoroughly assess your patient, and that is key into figuring out what to do when somebody has abdominal pain. You may not get a specific diagnosis, and that isn't really necessary. And treatment can be the same for most conditions, but recognizing different signs and symptoms is going to point you in specific directions. The abdomen is the region between the diaphragm and the pelvis. It contains many organs and organ systems, and it does the following functions: digestion, reproduction, and endocrine, and regulatory. So here's a picture of the organs of the abdomen. You have solid organs and you have hollow organs. Solid organs are very vascular and bleed easily if injured. They're solid. Organs like the spleen, the liver, the pancreas, and kidneys. Hollow organs hold a substance, like the stomach holds food. The gallbladder holds bile. You've got the duodenum, which is part of the intestines. You've got large intestines, small intestines, and you've got the bladder, and all of them hold a substance. If they become injured or damaged, that substance is going to leak out into the abdomen and cause irritation and infection. So the choice is, if you have an injured organ, do you want it to be a vascular one that you bleed to death quite quickly, or a hollow one where you have a chance for sepsis and you die slowly? The abdomen is divided into quadrants: right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. And then you have the epigastric region, which is above the stomach. And this is a picture of the quadrants. The organs of the abdomen, first of all, they're lined with what we call the peritoneum. It's a thin membrane lining the abdominal cavity, and it also covers each organ. The parietal peritoneum is attached to the abdominal wall. The visceral peritoneum covers each organ. So parietal is the outer lining and visceral is the inner lining, similar to the lungs. You have a parietal pleura and a visceral pleura. For the more organs of the abdomen, most are enclosed within the parietal peritoneum. But there are a few that are actually lie outside of the lining in the abdomen, outside the peritoneum, and those are the kidneys and the pancreas, and then part of the aorta lie in what we call the retroperitoneal space behind the peritoneum. The bladder and part of the rectum lie inferior or below the peritoneum. And this is a picture here. You can see the organs that are within the peritoneal cavity: the spleen, the liver, the gallbladder, the stomach, transverse colon, and ascending and descending colon. And you also can see the organs within the retroperitoneal cavity. They're outside of that abdominal lining. And you see the kidney, the pancreas, duodenum, the abdominal aorta. See all of those structures. Abdominal pain or discomfort. Be careful and look at page 605 and know the differences in the different types of abdominal pain. A lot of times there's test questions on these. First of all, there's visceral pain. So, visceral peritoneum is the lining that lines each of the organs. Remember? So, visceral pain is a pain that originates from the organs within the abdomen. There's fewer nerve endings that allow for only a diffuse sensation of pain. So, people that have a pain that arises from a visceral or the visceral lining of whatever organ it is usually describe their pain as dull or achy. Visceral pain can also be intermittent. A colic may result from distension and or contraction of a hollow organ. So if the visceral lining of a hollow organ is stretched or distended, or there's a contraction of the organs, that's an intermittent pain, or what they call a colicky pain. Persistent or constant pain often originates from solid organs. The parietal pain. This originates from the total abdominal peritoneal lining. There's a lot of nerve endings which allow for specific efficient sensation of pains. So these pains that are parietal are described as sharp. Pain is often severe, constant, and localized to a specific area. A tearing pain is the most common type of abdominal pain. It generally originates in the aorta. There's a separation of layers of this large blood vessel, which is called an aneurysm. And since the aorta is behind the peritoneum, it causes the pain to be referred to the back. So they describe it as a back pain. Then we have referred pain. It's a perception of pain in the skin or muscles at distant locations. So, the abdomen has many nerves from different parts of the nervous system. They pass through the abdomen. And those nerve pathways overlap as they return to the spinal cord. And then pain sensations sometimes are transmitted from one system to another. This is called a referred pain. Now, turn to page 605 and be sure and review each type of those abdominal pains. Now some specific abdominal conditions. Appendicitis. This is an infection of the appendix. Signs and symptoms would include nausea and sometimes even vomiting. Pain, often initially referred to the umbilical region, is followed by a persistent right lower quadrant pain. So if you have appendicitis, you might feel it around your belly button, and then it ends up in the right lower quadrant, which is where the appendix is. Now, the appendix can rupture, and that's a sudden severe increase in pain. And then it's a hollow organ, so once again the contents release into the abdomen, and it'll cause a severe peritonitis. Irritation of the peritoneum is what peritonitis is. It's usually caused by a foreign material in the peritoneal space. So if a hollow organ ruptures, it's going to irritate the lining. The parietal peritoneum is very sensitive, especially to acid-like substances. So if your stomach ruptures or your bladder ruptures or something like that, it's going to be very sensitive. And the irritation to that lining causes an involuntary contraction of abdominal muscles. So somebody that has something irritating their peritoneum is going to have cramps and spasms. Their muscles will contract. And they'll have abdominal pain and then rigidity. Cholecystitis is gallstones. This is an inflammation of the gallbladder. It's often caused by a blockage of its outlet by gallstones, cholecystolithiasis, hard to say. Symptoms are often worsened by ingestion of fatty foods. So signs and symptoms are severe right upper quadrant or epigastric pain, and sometimes that pain will be referred to the shoulder. There's pancreatitis, an infection of the pancreas or inflammation of the pancreas. It's common in patients with chronic alcohol abuse. Signs and symptoms, that's an epigastric pain, often referred to the back and or to the shoulder. A gastrointestinal bleeding. This is a hemorrhage within the lumen of the GI tract. It might be minor, but it can also be severe. Blood eventually has to exit somewhere, either through the mouth or through the rectum. A lot of times it's painless, but if they have gastric ulcers or holes in the GI system from the gastric juices, which are really acidic, it can cause severe pain and peritonitis. Some GI bleeding, if it exits out the rectum, will be present in a dark colored stool, maroon to black, and they call it a tarry dark stool. If it's frank blood from the rectum, it's a hemorrhoid, so if it's more bright in color. But if it's gone through the system, it'll be dark colored stool, tarry-like. If it comes out the mouth and they vomit blood, it can be a coffee ground like substance. It looks just like used coffee grounds. If it is more fresh, then it might be a bleeding that's higher up and not necessarily from the stomach. But the pain can be absent to severe in either case. Some people have abdominal aortic aneurysms. We talked about this before. It's a ballooning or weakening of the inner wall of the aorta. It tears and separates from the outer layers of the lining, and that weakened vessel will bulge and continue to grow, and eventually it can rupture. Then you have somebody that's bleeding to death, basically. Signs and symptoms of this. They'll feel a progressive, really sharp or tearing abdominal pain. It'll radiate to the back because remember it's retroperitoneal, the aorta is, and they'll feel it in their lower back. Sometimes you might feel an abdominal mass in their stomach, in their abdomen, and it could possibly be pulsating because that's the aorta. It's gonna beat with the heart. Possible inequality in pedal pulses. One might be present, one isn't. Signs and symptoms are sudden severe increase in pain, and it might indicate a rupture. High aortic pressure causes a rapid internal bleeding, suddenly progressing to shock. You see signs and symptoms of shock, and they can have a fatal hemorrhage. A hernia. A hernia is the hole in the muscle layer of the abdominal wall, and it allows tissues or parts of organs to protrude up against the skin. So basically their intestine is poking out. It can be precipitated by heavy lifting. It can cause a strangulation of that tissue or a bowel obstruction, and it requires surgery to fix it. Signs and symptoms of a hernia. Sudden onset of abdominal pain, often after they work or exert themselves. A palpable mass or lump on the abdominal wall or the crease of the groin. And if it's in the groin, it's an inguinal hernia. Renal colic. It's a severe flank pain caused by kidney stones traveling down the ureter. So signs and symptoms are severe cramping, intermittent pain in the flank or back. These are what they call kidney stones. Frequently reverted to the groin. Nausea and vomiting. Cardiac can also be felt as abdominal discomfort. So a heart attack might present as epigastric pain, something like indigestion or digestive discomfort. Always consider the possibility of a cardiac emergency as a cause of abdominal symptoms.
The most common location of abdominal aortic aneurysm is between the renal and iliac arteries. An aneurysm is luminal dilatation caused by degenerative changes in the aortic wall, leading to an increased vessel diameter and bulging of the abdominal aorta. Eventually, the degenerative changes may lead to rupture of the aneurysm.
So what do we do for people that have abdominal pain or discomfort? Well, first of all, there can be many potential causes of abdominal pain. Your role is not really to diagnose it. Focus your efforts on performing a very thorough secondary exam, your OPQRST and your sample history, and definitely identify any serious or life-threatening conditions. Protect yourself from bloodborne pathogens. Be aware of any odors you may smell. Determine if the patient's condition is medical, trauma, or both. Do a general impression, airway, breathing, circulation. Assess their level of consciousness. Consider application of oxygen, especially to any hypoxic abdominal pain patient or in any situation where an oxygen saturation is deemed to be inaccurate. For the onset, ask, when did it begin? What were you doing? Provocation. What makes it feel better or worse? Can you move and it feels better, or do you sit in a certain position and it feels better? Quality. Describe the sensation in your abdomen. Let them describe the pain to you. Don't put words in their mouth. Region or radiation. Point to its location and does it radiate or move anywhere? And then severity. How bad is the pain on a scale of 1 to 10? And then the time. Do you have pain all the time? Is it intermittent or has it changed? Specific to female patients, you want to get a good history because they may have some female organs that might be causing problems. So ask them, where are you in your menstrual cycle? Is your period late? Do you have bleeding from the vagina that is not menstrual bleeding? Or if you are menstruating, is your flow normal? Ask them, have you had this pain before? Most women that have menstrual pains know what it feels like. It doesn't change that frequently. So if so, when did it happen and what was it like? Is it possible you're pregnant, or are you using birth control? And then get your signs and symptoms, your allergies, any medications they take, any pertinent past history, when did they eat last, and events leading up to the emergency. And then for the elderly, remember they have a decreased ability to perceive pain. They have more serious causes of abdominal pain and more likely to be life-threatening conditions. And the other thing is their perception may be complicated by other medications. When you inspect the abdomen, you're looking for distension. You're looking for any discoloration or any protrusions that are sticking out that are abnormal. You want to feel. Use your fingertips and check the most painful area last. So feel the whole abdomen, and the part they say is painful, save for the last. Palpate for rigidity. And remember, rigidity is affecting the peritoneal lining. Pain, where is it at? What does it feel like? And guarding. Guarding is when they kind of pull their arm in and protect their abdomen. They might even pull their legs up, and it's called guarding. Take vital signs every 5 minutes. Check their pulse, their respirations, their blood pressure, skin color, temperature and condition, pulse oximetry, and mental status. General abdominal distress. Some will result from the digestive system disorders. Others could be cardiac or diabetic issues, food poisoning, or flu. So assess and care for these patients with appropriate attention to airway, especially if they're vomiting. You don't want them to aspirate. Always work to calm the patient, and that helps reduce their anxiety. And never give the patient anything to eat. Maintain their airway. Be prepared to suction and give oxygen to any patient that has a saturation of less than 94%. Place in the position of comfort. Uh, Left lateral recumbent for airway protection. If they're comfortable laying on their side, that's the way they want to sleep, then, or that's the way they want to lay, that's perfectly okay. If they're able to maintain an airway, transport them to the appropriate facility. So, you have an 89-year-old female with a history of diabetes, hypertension, and gallstones. She's complaining of nausea and dizziness about 20 minutes after eating. What do you think could be going on? The fact that the nausea and dizziness happened after the gallstones could indicate, or after eating, could indicate some more problems with her gallbladder. So you wanted to get a more thorough history, but also diabetes presents with sometimes the pancreatitis affects people that have diabetes quite a bit. So what are the concerns with this patient? Well, it could be cardiac, could be diabetic, could be gallstones. So how will you know? You may not know for sure until other tests will be done. But will this affect your treatment? Not necessarily. It's a good idea to kind of get a more thorough assessment, ask more questions, and you'll be able to narrow it down and maybe pinpoint some more specific actions. But for now, your treatment is to give her oxygen if her O2 sats are less than 94%. You know, get her to an appropriate facility, and maintain her in the position that she's comfortable in. Chapter review. All complaints of abdominal pain or distress must be treated as serious emergencies requiring transport. As an EMT, your responsibility is primarily to assess the patient and report your findings. Field diagnosing the cause of an abdominal complaint is often more difficult and time-consuming than diagnosing in the emergency department, where there are many more resources available than in the field. Your assessment should include a thorough patient history, physical exam, and vital signs. Look for signs and symptoms that can signal serious trouble. This includes sudden onset of tearing pain radiating down the back, vomiting blood or coffee grounds-like material, the presence of black tarry stools, or signs and symptoms of shock. Look to page 609 to see how to perform an abdominal assessment. Emergency care will consist of protecting the patient's airway, oxygen is needed, placing the responsive patient in the position of comfort, placing the unresponsive patient or patient with difficulty maintaining an airway in the left lateral recumbent position, and transporting the patient to the hospital. Take all appropriate standard precautions and carefully clean and disinfect equipment in the ambulance, especially if the patient has vomited or has had diarrhea. Abdominal organs provide a variety of important functions to the body. The abdomen can be divided into 4 quadrants with reference to the midline and the umbilicus. Classifications of pain can help identify specific abdominal dysfunctions. Assessment and management always takes a higher priority than determining the exact cause of abdominal pain. Knowledge of the characteristics of specific abdominal disorders can aid differential diagnosis when assessing a patient with abdominal pain. Read on page 616, Critical Decision Making, about assessing a patient with abdominal pain. Care for a patient with abdominal pain should include treatment of immediate life threats, administration of oxygen, placing the patient in a position of comfort, and appropriate transport. What are 5 signs and symptoms of abdominal distress? Describe the difference between visceral and parietal pain. Remember, visceral lines the organs, parietal lines the abdomen. So visceral is more diffuse and stretchy in hollow organs, kind of colicky. A parietal pain is more sharp and easily located. Describe a condition that may be responsible for each. What is the emergency care for a patient experiencing abdominal pain or distress? Does it vary much depending on what's wrong? Not a whole lot. Some more specifics, if you were a paramedic, you might be doing few more specific things, but the basics are pretty similar. Name the 4 abdominal quadrants. How are the quadrants determined? They're divided like a cross right through the belly button, and you have the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. So you're called to a patient with abdominal pain. He describes the pain as severe and says it has been on and off over the past several days, becoming severe within the last hour. So he's in an intermittent pain. It comes and goes over the past several days, and it's starting to get more severe within the hour. Can he localize it? You need to get your sample and your OPQRST questions and start with a very thorough background. What was he eating? What brought it on? Does he take any medications? Specifically, what does it feel like? So, asking these additional questions is going to help you in writing a very good report and passing it along to the doctor. What position would he likely be most comfortable in? Probably sitting up.